Uh, Thanks for the introduction. I am from New York City. I hold a couple of roles in our department. I'm the medical director, vice chair for operations. I'm also for the medical center, the brand new associate chief medical officer, information officer for metrics and outcomes. My big message today is this one slide. The train has left the station as far as implementing and considering implementing ED information systems. We're past the discussion of whether or not you're going to. You have to. I'm going to talk about some of the reasons why and some of the legislations that occurred that is making it a foregone conclusion. And I'm also one of those kind of positive people, I think I have to be considering where I work, that is always trying to look for the positive and trying to make the best out of the situation. And I think that's my other message is you can catch the train, you can get on, and you could make whatever you have better. I do some work. I have a consulting business. I do some consulting. I've done some for Pisces, done some talks for Epic. Data Park's a cloud company that I chat with sometimes. I also am funded by CMMI, the CMS's Innovations Grant, and a United Hospital Fund grant. So I like this picture because it looks nicer than it is. We're in that little tiny corner down on the bottom, and it makes me feel so small, and what we do so small. And we like to think of us as emergency physicians as being so important because we take care of people who are acutely ill and injured, and that is important. It's important to our patients. It's important to the society. But as far as the healthcare system, we're a part of it. And implementing electronic health record is a part of the solution in fixing broader healthcare. I just finished a book by Spooner and Reese on accountable care organizations. It's called Accountable Organizations Bridging the Healthcare Information Technology Divide. Great book, highly recommended. But what it really made me understand, even more than I thought I did, was where we are at this incredibly exciting time in healthcare. He has this one graph in the introduction where he talks about the aging population, which we all know. Sherry's going deaf, and I'm going blind, taking my glasses on and off 5 million times in a day. We're all aging, and the population is greater than 50% of the population is going to be over 65 in 2020, very soon. We have an increasing complex healthcare system. Everybody agrees. That's a definite truism. And we need to innovate, and when governments say that and people say that, that means we need to cut costs. We need to figure out better ways to manage populations and manage utilization. And in order to do all that, we need better technology, and we need to implement, and we need to stop complaining about implementing, but be engaged and do it and be a part of it. I sound like I'm preaching. Anyway, the big game changer for information technology was the Recovery Act. It was not healthcare reform, but it was the Recovery Act in 2009. And that's where high tech was put into legislation. And what this is all about is it set up a framework for healthcare reform. It's all about care coordination, quality improvement, improved efficiency, and population health. We're part of the population health. We're in a team sport in the emergency department where we're taking care of the acute illness and we're participating in a team. I love Jay's talk. We're using pharmacists in our ED, in our geriatric ED, and for any patient with more than 7 medications gets an automatic pharmacy consult. It's a team, but we're not alone. We're working together in order to improve the outcomes and well-being of our patients. The High-Tech Act had $2 billion, which was the incentive for hospitals across the country to say, ooh, I got to do this. And I feel, as President Obama felt, that this was the most important healthcare system legislation since the 60s. And that's not just because I'm a geek and now the geeks rule, because now we're all at the table and it's kind of really exciting to be a geek in healthcare right now. But it really did change the game because now we get data. And for all the data geeks in the room, if you have data, you can know what's happening. You can look at it, you can analyze it, and you can figure out what you want to do differently the next time. I did so well, but it's all about carrots and sticks in the legislation. What goodies can we give you, and how can we penalize you if you're not doing what we want? This is a big thing too, which is kind of painful for emergency physicians because EPs are not EPs. So what the legislation says is that emergency physicians are hospital-based. And that's a little tough pill to swallow if you thought of yourself as a private group working independently. And what the legislation says is you got to work with your hospital and figure out a system that works and makes all the metrics happen, or you got to use the hospital system. And you got to do it either way, so it's best to be part of the conversation instead of just being told what to do. And for all those folks out there who are Meditech or Allscripts site, I don't know if you saw the new class report, I feel for you. It's tough being with vendors that have bad products, but in order to make the bad products good products, you have to be involved and you have to be engaged to make them better. I'm not saying anything out of school because it wasn't my report that said that. I happen to agree with the class report, but that's just what it said. MU1 eligible providers, these are for folks who have urgent cares or freestanding EDs. I'm CEO of an urgent care, just opened one and going to open up another one in a couple of months. And that is a way of getting eligible provider dollars out of meaningful use. These are the criteria, and I put a lot of content in the slides just so you have it there, but I'm not necessarily going to go through it all. The payments are significant, especially if you're running a large multi-physician urgent care center or freestanding ED. You can really make up some money. Granted, it's not going to pay for your implementation, especially if you have an Epic implementation. This costs tens, if not hundreds of millions of dollars. But it is something, and it does help. And more importantly, if you don't do it, and you don't participate, and you don't get the money, your hospital administration or your group, they'll know. So now you're an emergency physician, you're working for a hospital. What is it that they want you to do? They want you to meaningfully use that electronic health record in order to care for patients. Why? Because they want data. Remember, the whole goal of this is to better manage the population and to better care for your patients and to better get them the resources that they need to stay well in this society. And the only way they think they can do that is by having data. So the incentive payments are there, $2 million plus $200 per discharge. Once again, it's real money. The big thing is the 2015 is the stick. It's a significant stick, and it's 25% of your market basket. And for those large healthcare organizations, that's real money. That's more than your margin, and you will lose the game, the race of profitability, if you don't comply. The other big thing is, are we counted? Are our emergency department patients counted? And this was, I'm the incoming president of the ASAP informatics section, and a lot of the informatics leaders bantered back and forth as to whether we should or we shouldn't be. What should we do? How do we want to be a part of it? Should we be a part of it? You can be counted or you won't be counted. But because we're good at what we do, and because our nurses are great documenters, and because our practitioners are engaged with their patients and engaged in gathering data, lots of hospitals look at the ED as a great patient population because it changes the math. Instead of looking at their 12,000 inpatient discharge and they're only compliant with 5,000 of them, now you add the 40,000 patients in the ED and all of a sudden you meet the over 50% mark. That's why we are engaged in this conversation right now instead of later. So what are the core measures? As you all know, I saw Jim's data on CPOA implementation. It was really encouraging to see that, it is a foregone conclusion for many of you. It's a foregone conclusion that you installed, and it may be a foregone conclusion that you implemented, but it's not a foregone conclusion that you've optimized and maintained your system to prevent unsafe events from happening and to prevent hazards from happening in your patient care. And I think that's another message I really want to bring to you. Heather, I think, is here somewhere. Heather Farley and I, there she is. We're just finishing at lunch today, hopefully. The final edits on a paper that got accepted on EHR Safety. It was a joint project between the quality section and the informatics section at ASAP. And we do realize that there are hazards involved in using these systems, and we want all of you to be engaged, especially every ED to be engaged in making the systems better. Anyway, that was a little sidebar. CPOE is the big one. It goes from 30% to 50% at MU2. As you can see, the items on the list include all kinds of information that you're gathering in the front line. Problems on the problem list. What's their med list? What's their allergies? What's their vital signs, greater than 50%? What's their smoking status? It's not just that you document it, though. It's where you document it in the record in order to generate the report so you meet compliance. And that's also one of the challenges you have to think about when you're designing your system. Where is this in the workflow? Where do I naturally ask it? Where do I ask it again? Who asks it? There's nothing in that says the doc has to do every single data entry item in the whole electronic record. You're a team sport now, and your team can document in the record that a provider is creating for a given encounter. The quality measures are a big deal. Does it show up red there? Yeah, it shows up red there. Because there's some throughput metrics in the quality measures that make a difference, and we've kind of started talking about that already today. The part about giving a patient electronic record or access to their record after ED visits, a challenging one for us, but the conversation's just starting, and we're going to continue having that for the next couple of years. So for me, the game changer was the throughput metrics. You have to understand, I work in an ED that's 15,000 square feet. We saw 102,000 patients last year. We are packed. And we have a border problem that is incredibly significant. We only admit about 40% of the patients to the hospital, their total discharges. But that means is surgical procedures, complex surgeries, and catheterizations are where they make their money. The ED is backfill. We have a 10.5 hour length of stay for our border patients. So, and there's lots of large urban centers that are specialty hospitals that have huge, significant border problems. And this is a big deal to us. This we fought really, really, really hard for, to get the admit decision time to departure time, something that is being tracked and reported on so that we can make the hospitals fix our overcrowding problem. So for us, this is a really big deal. It's how meaningful use could be meaningful for another problem. So what do we need to do? Height and weight for all. Discuss smoking cessation and document the appropriate place in the record. And the other thing is advanced directives. We do a lot of advanced directives discussions. We do a lot of noting that patient has advanced directives. Yet again, it's where it is documented in the system and how it can be retrievable for all the practitioners along the healthcare continuum. So MU2, it's just a couple of changes. It's nothing really that big for the e-prescribing thing. I personally am not a huge fan of. For some reason, I just like giving the patient a prescription instead of electronically sending it. I don't know what it is. That's a tough one. You can set up your system so you can electronically send and give a prescription if you have folks like me working in your place. The health information exchange is an important element, and I think that HIE is how we're going to knit together different hospitals and different communities so that we can exchange information. And with a lot of work that a lot of people are doing on standards, standardizing how data is sent back and forth, we'll be able to do that so we can link together and knit together disparate systems. The view online and download is a big deal because we're thinking, how in God's name am I going to do that? How am I going to engage the patient? How am I going to make them engaged? I can tell you, our house right now, we're already over 7%. That are actively using their patient portal in order to engage in information. And we just started this about a year ago with the patient engagement. And I'm pretty surprised because our patient population, we're in the middle of Manhattan, so we have a wealthy population and a very poor population right around us. And patients are pretty into it, so it's pretty exciting that they're participating already. So, in summary of this part of the talk, the train's left the station. Be a clinician champion. Just become engaged. If you're using an iPad or using a computer or using an iPhone, you too can be part of technology. It's not that hard, but learn it. Go to the classes. Learn what the application can do with your vendor. Be a part of the conversation. If it means taking some time off to actually learn the reporting tool or learn how to compose. It's just knowledge that you can have so you can engage in a conversation with the vendor to make your product and your work environment all the better. And get paid for it. Advocate in your site with your administration to get paid because those sites that have physician-clinician engagements have a better implementation, happier staff, and better patient care, and can better meet the needs of the future of all the other quality metrics that are coming down the road. To that end, I wanted to give a little bit of specifics because people always ask me, well, can you show me really how that works? Can you give me some examples of what you've done with your implementations? I'm going to give you a small example. So core measures. I spend a lot of time talking about, in my other hat that I wear, talking about what are the core measures, how are we getting the data, where is the data coming from. Core measures are supposed to be quantifiable, universally relevant, and achievable. How many people in this room have been to the NQF website? Not a lot. So NQF is National Quality Forum, where metrics get made, where they give birth to metrics. And if you will, which is kind of true. But the birthing process can be painful. You can have a smack of that baby, and they can be changed, commented on, critiqued, and even once they don't have to necessarily be forever. So glucose control for the ICU, beta blocker after MI, antibiotics for pneumonia in 4 hours. We love pneumonia patients. Pulse ox for all pneumonia patients. The thing about core measures, too, is they sunrise and then they sunset. So the whole concept is if you reach 100% over time, we've got it. We're doing it. We're okay with that one. And we come up with the next one. The next big one coming down the line is the severe sepsis quality metrics. So comment now and comment quickly unless you feel like putting central lines in your patients who have severe sepsis. So anyway, the one that we were focused on is antibiotics, blood cultures before antibiotics. And this was a quirk of how our nurses do the workflow. And also, we got stuck with the azithromycin, using the azithromycin for the atypical coverage. We kept getting dinged on that. So we needed to figure out a solution to try and make it better. They're ordering the Venco. Jay talked about Venco too. My gung-ho docs are ordering Venco and cefepime, and they're forgetting the Zithro. And how do we prompt them without torturing them? Because we all can have a whole huge, long conversation. We'll talk a little bit about alert fatigue. You can have these core measure people, chart review people, who are so anxious, and they say, just put alert in, just make them stop, put a hard stop in. But how do we do it in a more elegant way that's not torture for the providers, that thinks a little, and make it better without torture? Or nudge them. There's a great book by some folks out of Chicago called Nudge, which I really love to use when I'm having conversations about clinical decision support. There's lots of ways to get people to do things instead of stopping them or alerting them. You can think about it and be creative about it, and that's the really fun part of what we're doing in health information technology now. So anyway, we looked at all the pneumonia diagnoses where we put in a clinical impression, and we found all of the IC9s associated with that. And then we wanted to figure out how, after you put that in, how do we prompt users, and what do we say? And one of my junior faculty is a lot wordier than I am. But you put this very wordy, lengthy, hey, are you sure you want to do this, or are you sure you don't want to do this, prompt in to the record. Unless the provider, but they only get the warning if you didn't already put the azithro. So if you did everything right, and you have the pneumonia diagnosis in, you're not going to be tortured, keep going. Versus being prompted at the front, these are the antibiotics you should use, you're a child, do it this way. No, we're clinicians, we went to a lot of school, we worked really hard to get where we are. If you do it wrong, a little nudge, and then move on. We use Epic right now. We've used Pisces in the past. I've experienced using different vendor systems. All the different vendor systems can do these things. But the important thing is to workflow it out. I wrote a paper on process redesign, and there's all these consultants that use Visio and all these crazy things. Just use Excel and make swim lanes. Put all the people that are doing something and all the actions they do. Just write it down and look at it and figure out where you want to make the change. I love color coding the processes so that you can see which information system they're using in, so you get a really clear picture of what's going on. So there's just a little slide in here for those Epic folks so they can bring back to their technical people to help them build changes in their alerting system as well. Having clicker problems, I'm sorry. So alert fatigue. I did want to mention something about this hot topic that my colleagues are talking about all over the country, because I think there's a lot of people who feel that the more you alert, and there's some literature to support this, some good literature to support this, the more errors you make instead of the better. And I think you have to think about it. You have to have a clinical decision support committee and an alert council, and you have to analyze your alerts that you put in and decide whether these alerts are working or they're just torturing your nurses or they're torturing your doctors. And then tease out how you can redesign them and make them better to get a better end result. And these are kind of things that people don't necessarily complain about until you're directly asking them in a meeting. It's like, oh, it's such torture. And what happens is they just blow past them. And you blow past alerts, you're potentially harming someone. So that's the big deal about this, is by over-alerting, we're actually causing more harm than we are preventing the harm. And then the informatics people don't look so good because we just seem like, I don't know, geeks kind of doing things to torture us. So I have a couple examples. These bells, it doesn't show up quite right, but if you bell everything, if you alert everything, you alerted nothing, right? And then look at this trackboard. There are like a gazillion things on this. How do you, like Sherry was saying, how are you communicating which is the most important or relevant piece of information? Is it that 27 minutes that has gone by before this EKG is done because you passed your metric for EKG? Is it that you're waiting for lab results that the lab says everything's an alert? I mean, maybe you have a good experience with your lab. To our lab, everything's out of range. So you're out of range for a 3.4. Who said 3.4 before? Oh, that's out of range. You're like, who cares? So you have to figure out how to alert your system, and then you'll start one way, and then you're going to change it over time and synthesize out. Right now, we're left with just the red X, because the red X is the only thing I care about, and the red X is the patient needs to go to X-ray. And all the other stuff is nice to have information, and these vendors will build you all these really cool things that some client wanted somewhere. But for us, all we want to know, did that patient go to X-ray or not? Done. Stops. I hate hard stops. Use them incredibly, incredibly gingerly. Your team will absolutely hate you every time they have to stop what they're doing and be forced to go backwards instead of forwards. If blood cultures are ordered, I like this one a lot because we're at a large academic teaching hospital. And we would see the patient, evaluate them. They're not quite able to go home. Maybe they're a little bit hypoxic, or they're elderly and their support system, and we can't figure out a transition plan, or their comorbidities, and they're just too sick to go home, but they have pneumonia. But we don't think they're septic. We think they're going to be okay in a couple days after antibiotics. So we as clinicians do our gig. We draw labs, we give them 5 antibiotics, we admit them. Now, the incredibly prestigious medicine professor comes along and tortures his intern because they didn't draw the blood cultures. So we get a ding because that blood culture is happening after instead of before the antibiotics, but we didn't think they needed a blood culture because the patient's going to get better in 24 hours, and 99 times out of 100, they do get better in 24 hours. But we get the core measure ding because the blood culture was ordered after the antibiotics are given. I hate this one, and I hate sitting in that stupid core measure meeting and have to explain it. And it was driving me nuts. I see nods because y'all agree. So we decided that we would work with the Department of Medicine, which is a good thing, and we always want to do, and to figure out a way of prompting users to get an alert if they try and order the blood culture after the antibiotics are already given. And so this is what it looks like, and it's a little bit punitive, but it's a little torture, but they have to know what they're doing, because I don't think most times the intern doesn't think, oh, I'm violating a core measure and I'm gonna get us a ding. They just think they're doing what they're supposed to do and getting a blood culture on a patient with pneumonia. And so if it's not a pneumonia patient and it doesn't hit in those ICD-9s with pneumonia as their clinical impression, and if they didn't get antibiotics, yet again, it's a directed, focused alert for a specific target population. We're 100% time, month after month now, and we made it. So I'm very happy about that. I got a couple more minutes just to talk about this safety paper that we've been, Heather and I have been loving, and Suzanne too, and a couple other people in the room. We came up with a sort of structure, if you will, and hopefully some guidance on how to run your own EHR safety committees, which I think is an essential to any department who has an electronic health record, is to not just put it in and not just optimize it, but to continually think about it and how it's being used in your environment. And we have a medical events reporting system. Does everybody have an electronic system, event reporting system? Raise hands if you do. Oh, okay. So we encourage and categorize anybody to put in an event that's an error that they think has something to do with the electronic record. Even if it's not in the end, we just want them to put it in, and then the team will analyze it. So we get all of them, we look at all of them, we take it incredibly seriously, and we bring that to the team. We also get reports about alerts. We look at all of our alerts, every single one, how many they're doing, who's using them, who's not, and try and figure out ways to do it better. We look at wrong patient, wrong order, error type. We just had a real one, and I hope I can say this, but I'm going to say it anyway. The wrong patient got 4 milligrams of Dilaudid and 4 milligrams of Ativan at the same time, a liver patient. The intern put the order in for a patient that was boarding in the ED, but she thought she was putting in for a patient that was on the floor. She was busy, she was quick, it was middle of the night. The nurse did it, which is the most amazing thing to me. Because it was crowded, the nurse had 12 patients. It was a busy ED. I can't blame her. But nonetheless, it's considered to be an epic failure, an IT failure. I don't know if that's true. And Sherry would have issue with that, I think. But nonetheless, we'll talk about it in the community and come up with ways to make it better in the future. Poor data display is when something is in a report, in a data output that shouldn't be there or is there, and that data display is being used by somebody else, maybe a chart abstractor or a clinician, and to figure out ways to communicate better using the document, the electronic version and the document. And there's lots of them. Communication failure. I didn't know Sherry and I were having such synergies in our talks, but it is so true. I hear it all over the country when I talk. Information systems do not improve communication. They do the opposite. They make people not talk who have been friends for 15 years, and now they don't talk to each other, and they just put the thing in they like literally do a nursing communication. Instead of going up and talking to each other, they'll like passive aggressively put nursing communication, I need a rectal temp. Why not just go up and say, I need a rectal temp? What's the big deal? We're actually looking at all of our nursing communication, which is an order type, which I call the passive-aggressive order type. We're looking at them all, doing an analysis of who the providers are using them, and putting it to communication class. So they talk to each other instead of doing passive-aggressive behavior. And there are other strategies about communication, too. We've implemented bedside rounding, rocket science, with the nurse and the doc and the patient at the bedside. When you have 25 patients, sometimes those barriers are down. Doctors actually pushed back on this. I couldn't believe it. But they said, oh, they know what's going on. No, that one's admitted. But they didn't have the in-face communication so that when something is going wrong, they're talking to each other, not just putting things in the computer. Like, you wouldn't believe some of the notes you see in the computer that the nurse wrote that they never talked to each other about. It's the most incredible thing. It's because we've developed this place where we think the computer's going to solve everything. It's not. It's a tool. It's a tool to get data so we can better care for populations. But we still need to take care of the individual patients in front of us, and I don't want to lose that at all. So a big thing about EHR safety, just quickly, is internal reporting and how we're going to report out to patient safety organizations. The debate goes on. We feel that you have to have a reporting system, at least internally, and who the organization, ONC, AHRQ, whoever, some alphabet soup agency, we hope someday will be able to receive reports on hazards in your electronic health record, synthesize them, and report them back to you, the community, so that you don't keep repeating the mistakes that I just made, so we can all share our mistakes and learn from them. And I am 1 minute and 38 seconds close. That's my email. Feel free to email me if you have any questions, and I'll take 2 questions right now. Yep.
We use Pisces.
Yep.
We implemented a lot of good things with it, but it doubled our triage time. And so we've it's helped create a bottleneck at triage, especially about doing the medication reconciliation. What solutions have other people used? Have they broke triage into steps?
So cut your triage template in half. It's just an electronic template. There's no reason you have to ask all those questions at the front. There's other providers along the continuum of care who can do medication questioning. For some, and develop a quick triage. Pisces has the ability to do triage and quick triage. Set metrics for when you're over 4 people waiting. You switch to quick triage, and then your primary nurse who has more time can ask the rest of the queries. Or have your pharmacist ask the current medication list. Brilliant. They love that part. We hate that part. Let them do it.